In this video, we'll do an exam review on subdural hematoma. Three layers covering the brain and spinal cord are: number 1, dura mater, outermost; arachnoid matter, the middle one and is avascular; and the pia mater is the innermost. So where is subdural space? The subdural space is between the dura and arachnoid matter. The subdural hematoma may be caused by contusion or other head injury. So what happens in subdural hematoma? Severe cerebral compression causes temporal lobe herniation leading to death. So CT and MRI should be done quickly as mass effects and increased intracerebral pressure may be life-threatening. So subdural space is between the dura and arachnoid matter, and the hematoma is caused by head injuries, and brain compression may cause herniation leading to death. That's why investigation should be done quickly to prevent the mass effect and increase intracerebral pressure. So what are the causes of subdural hematoma? Most often it occurs due to car accident, but it also occurs in elderly, alcoholic, and in shaken baby syndrome. So the most common cause is a car accident, but also occur in elderly, alcoholics, and shaken baby syndrome. So how does subdural hematoma occur? Blunt and counter-coup injuries and hemorrhage that occur opposite to injury occur due to deceleration injury to the brain, causing rupture and bleeding of the bridging emissary veins that connect brain and sagittal sinus, leading to hematoma formation between the dura and arachnoid. So the blunt and counter-coup injury due to deceleration causes rupture of which blood vessel? They cause rupture of the emissary vein that connect brain and sagittal sinus, that leads to hematoma formation. So it's a venous bleeding. Venous bleeding is slow. So slow venous bleeding in subdural hematoma causes slow onset of clinical features due to slow accumulation of blood. Mental function decline takes place days to weeks to appear. So it's the venous bleeding that occurs in subdural hematoma, and it's a slow bleeding, so slow onset of clinical features, so the mental function decline takes days or weeks to appear. The bleeding can cross the suture line, but it does not cross the midline. Now the clinical features of the subdural hematoma depends on hematoma size. So let's do the clinical features on hematoma size. A small subdural hematomas are asymptomatic and require no treatment. A smaller one asymptomatic and no treatment. Number 2, subacute subdural hematoma. Signs symptoms appear weeks after the injury but not immediately. Minor trauma in elderly and alcoholic also causes subacute syndrome days to weeks after the injury, with drowsiness, headache, confusion, and mild hemiparesis. So the acute one was symptomless and no treatment, and subacute subdural hematoma also occurs weeks after the injury and also occur with minor injury in elderly and alcoholic and causes drowsiness, headache, confusion, and mild hemiparesis. Now larger hematoma. In large hematoma, lucid interval is brief and is followed by coma. So brief lucid interval in large hematoma followed by coma. Most patients are drowsy or comatose from the moment of injury. In large hematomas, most patients are drowsy, sleepy, have ipsilateral headache, and ipsilateral pupillary dilation may also be present. So in large hematomas, the lucid interval is short. Patient is drowsy, sleepy, with ipsilateral headache and ipsilateral pupillary dilatation. The other features like stupor, coma, and hemiparesis occur in larger hematoma. Now number 4, chronic subdural hematoma. 25% of patients with chronic subdural hematoma do not recall a head injury. So the history of head injury is missing in chronic subdural hematoma. But headache in chronic subdural hematoma is common and varies with the position of the head. So the headache depends on the position of the head. And in chronic subdural hematoma, other features are personality changes, slow thinking, and mild hemiparesis. So personality changes, slow thinking, and headache that varies with the head position. Incoherent thoughts are more prominent than focal neurological features in chronic subdural hematoma, and seizures may originate from chronic hematoma site. In the investigation, X-ray skull may be normal in subdural hematoma, or there may be pineal gland shifting due to pressure and mass effect, and in long-standing cases there is calcification around the hematoma in chronic subdural hematoma or long-standing cases. Now CT scan. Bleeding produces a crescent-shaped hematoma, most commonly in the frontotemporal region, and that does not cross the midline but it crosses the suture line. See here, the bleeding does not cross the midline, but it is crossing the sutures, and it's crescent shape, and most commonly in the frontotemporal region. In chronic cases, CT without contrast shows low density mass in 2 to 6 weeks. So in chronic cases, CT will show a what type of mass? Low density mass. What happens in bilateral chronic hematomas? So in bilateral chronic hematomas, shifting may not be seen, but it produces hypernormal CT scan. So in bilateral cases, normal structure position, no shifting with hypernormal CT scan, wherein in chronic cases with CT without contrast, they have low density mass that develops in 2 to 6 weeks. But in bilateral cases, no shifting with hypernormal CT scan and small ventricles in elderly. MRI is reliable to identify subacute and chronic cases. Now, treatment of subdural hematoma. Small symptomless hematoma do not require glucocorticoid treatment is enough for many hematomas. Now, the surgical treatment of the hematoma is by Burr hole or craniotomy to remove large hematomas. Fibrous membrane around the collection is also removed.